Hey, everybody, and welcome to whatever this is going to be on the Overrun. My name is Ed Bowder.
I'm Dan Schweizer.
We are doing a Monday afternoon journal club now. So what we'll do is every Monday we're going to start talking about and releasing some EMS data that's available in case you haven't seen it. So the idea is that we look through some data, look through some information, see what's interesting, see what might actually be practice changing, and just try and keep everyone sort of up to date on what's going on in the world of resuscitation and EMS medicine. So today we're going to talk about low-titer whole blood and blood transfusions in the field because they're sort of a pressing topic.
Big topic,
especially a
big topic in the FOAMed world and social media. This is the new. I think this is the new cool thing. But interestingly enough,
it does kind of feel that way.
There's some stuff behind it though. As we
and it's nice to have a new thing that at least feels like it's supported by some of the data, right? I think a lot of times in EMS and in medicine in general, we're like, oh, here's a brand new study. And it doesn't actually change anything. And there's certainly a million anecdotes that we can get into where, you know, this is the new hot thing is going to change everything. And it turns out that it doesn't actually work. So today what we're going to talk about, again, we're talking about blood products being administered in the field. And there's been a bunch of studies that have come out as far as giving blood products are concerned. So this comes out of the Journal of Trauma Acute Care Surgery in 2023. This is maintaining whole blood center transfusion improves survival and hemorrhagic resuscitation. So what's interesting about this study, and this is by Feinberg et al., you can see up here, they're affiliated with Brown University, which in the interest of transparency is where I currently am a student. But essentially what they looked at in this study was they looked at mixing components of blood products with whole blood to see if adding blood components with whole blood at a certain ratio, 2-to-1, 3-to-1, 4-to-1, would help improve outcomes. And you can see here on the screen that the analysis shows that higher packed red blood cells to whole blood ratios at 4 hours diminished survival benefits of whole blood and trauma resuscitation. Obviously, every good study will end with further efforts to emphasize this relationship to optimize trauma resuscitation protocols. And certainly there's more data that needs to be done to actually elucidate an actual answer. But this debate whether or not we need to give whole blood, blood products, packed cells, platelets, plasma, all that stuff, this study really helps us to kind of understand what works better. Now, as you can see here, the N is 3,884. They did have 17,562 patients, and they excluded 13,678 because they only had packed cells. So we still have a very good N of over 3,000, almost 4,000. And they used this 3-to-1 point for optimal cutoff. They looked at 24-hour mortality. So what I thought was interesting, Dan, about this is I feel like it adds to the debate, but it almost sort of, it helps to confirm or lead toward confirmation that whole blood is what patients who have lost blood need. And it feels like kind of an obvious thing, right? Like if your car loses oil, you have to replace oil. If a human body loses blood, you have to replace blood.
Yeah, it's what trauma patients crave. It's Rondo.
It's the best marketing theme. Whole blood. It's what trauma patients crave.
Right, and it makes complete sense. And this is something that's being borne out more and more with more and more studies coming out with the military medicine studies. People like Andrew Fisher and John Holcomb, who have done studies on this stuff back, in the war, the war on terror. Whole blood works. It makes sense. It's more physiologically normal fluid than giving component therapy. Just the fact that the platelets and the clotting factors, you're getting 100% of that with whole blood. You don't get that with component therapy. And even your component therapy really only gets you like 80,000 platelets. If you had 80,000 platelets walking around, you'd have a problem. It's not optimal fluid. It's something that's come into vogue. And again, I think when it did come in as component therapy, there wasn't, like most things in medicine, not a lot of studies to support or not support the idea. And we just adopted it.
And again, to borrow something from our friend Kevin, absence of evidence is not evidence of absence. So, and again, any research, any study is going to need more data, and we need more research and everything. But for years, we talked about like, all right, we can't give whole blood in the field for X reasons, and we'll get into that in a second. So component therapy seemed to be kind of the next best thing, where, you know, whether it's cost or storage or any other variable that an organization might have, it seemed like, okay, well, if we can't carry whole blood, let's carry packed cells, right?
Right.
The problem is packed cells will work for a patient who needs more circulating hemoglobin, more oxygen, right?
Right.
But in trauma, the problem isn't that the patient lacks packed cells. The problem is that the patient lacks A, the blood that they lost, and B, platelets.
But they've lost.
So,
But the trauma patients lost everything. They
right.
haven't just
Yeah, of
lost
course.
red blood cells. They've lost plasma. They've lost the
Yeah.
clotting factors. They've lost platelets. They've lost the serum. They've lost all of this stuff, and we don't replace it. And then we wonder why they don't get better.
No, absolutely. And that's the issue. So, you know, again, every good study will say that there's more data that needs to be looked at. So in 2024, in the Journal of Thrombosis and Hemostasis, Susan Shea et al. Discussed doing more with less. Low-titer group O whole blood resulted in less total transfusions and an independent association with survival in adults with severe traumatic hemorrhage. Now, once again, before we get into this, when you've seen one study, you have seen one study. And, you know, this isn't necessarily a diaspora, but if we know based off of an N of almost 4,000 that giving, you know, component therapy and whole blood doesn't really work and increases mortality, decreases benefits, then we have this study that shows that giving low-titer O whole blood does actually improve survivability. It's associated with improved survival, which was most evident in patients with coagulopathy or shock, right? And this is a safe medication to give, a safe intervention to give. So again, here we have the background, the abstract. The hypothesis for this was that whole blood would improve 24-hour survival. And here again, 348 patients is not a huge N, but in this conversation, we want to compare it to the previous, right? So we had 4,000 that show that component therapy with whole blood doesn't work. Here we have 348 patients that shows
it's
really it's not at all. No. I would rather have, I would rather have 348 than 34 or 38.
Yeah, I agree with you. I think these small number studies, look, I'm glad you're getting published. Good for you. But
right.
I worry that you're not really getting a good sample size and you're not getting good data. You know, like as we've said before on the show with a lot of things, it's garbage in, garbage out. If you're not getting enough of good data in there, you're not going to have a good outcome at the end.
No, absolutely. And a study like this, you know, typically if you're looking for a good N, you want to get like at least 50 people, right?
Yeah, I'd agree.
348, I think, is good for this. Obviously, there's always more people you're going to get. You can always say that, oh, the study could have been better. I'm generally okay with the methodology of this. This is an observational study. So there were no actual interventions that were done. And this was they used what's called a Cox regression to determine 24-hour mortality. A Cox regression is usually used on cancer patients, and it's just a way to access mortality. We don't really need to worry how it's actually done. So the results here, they looked at low-titer O whole blood, and what they found was you had a increase in 24-hour survival. You had a 40% reduction in blood product use, which comes down to a 2.4 liter reduction in transfused products. Now, before we get into what all that means for us,
so
one thing to mention, wait, just real quick before we get into it, because I also want to point out 6-hour and 28-day mortality were still similar in the groups. So if you go on to the Overrun's TikTok, I talk about this in one of our quick segments where here we have improved 24-hour survival, but not necessarily improved 28-day survival. So when we say all studies need follow-ups, this is what we're talking about, where now, okay, we know that products with whole blood don't necessarily work. We know that whole blood can improve 24-hour mortality, but not necessarily 28-day mortality.
But so the question needs to be why. That's the next question.
Why? The question is why, and what more can we add?
At 6 hours and at 28 days, which it doesn't make sense. It seems counterintuitive, but that's why we need to study this more.
No, absolutely. And when I see stuff like this, right, low-titer O whole blood was associated with improved survival for patients in shock with coagulopathy, right? I like that because this is essentially what we're trying to do, right? We want to get these patients who are in traumatic situations, who are in shock states, who don't have enough perfusing blood, we talked a couple minutes ago that it stands to reason that if you're a trauma patient and you lose blood, you should get blood, right? So now we have this data that actually supports that, right? 24-hour mortality is reduced, 40% reduction in blood products. Awesome. The next question is, what are we missing with that 28-day mortality? Now, one of the problems, I think, with trying to find that data is that there's so many variables for 28-day mortality that it's really, really hard to control for one single thing,
Yeah,
right?
absolutely.
So it's hard to say if I gave whole blood to this patient who was in the trauma bay and they survived 24 hours and then we release them from the SICU down to step down or med surge or whatever, and then because of their stay in the hospital, they develop an infection or they have a fall or whatever. Those 28-day mortalities are not necessarily tied to the original insult. So processing that data is very, very hard. I'm sure there's someone out there that's probably trying to generate a data set from this, but it's going to take time because you have to sit and filter through the data set and find that the actual independent variable was just that the patient was bleeding, received these things, and then either survived or died. So while I appreciate the 28-day mortality thing isn't really changed, I do think that that's a Herculean effort to undertake to say, almost conclusively or scientifically that whole blood affected or positively or negatively affected these things.
Yeah, I thought this was kind of interesting. I mean, first and foremost, that all of the patients that were selected for the study were in a massive transfusion protocol situation. So we're talking about heavy blood loss, really
huge trauma. Yeah.
And, usually units and units of blood that go into these patients and end up on the floor until they get hemostasis in the operating room.
Sure.
That was interesting to me. The 6 and 28-day mortality, I'd really like to drill down and see why those patients did not do well, especially if they seem to be better at 24 hours. Were they selecting patients that was this a Hail Mary throw? Was it where? There's things we can.
Yeah.
There's
always
we can suss out from this to find out. Hey, this is a person who's a really good chance for a massive transfusion. This is a person that's not going to do as well. Was it blunt or penetrating trauma? We're, again, not sure. Again, like you said, with the 28 days, was it hospital-acquired infections? Was it pneumonia? Was it barotrauma from the ventilator? We don't know. And these are things that are going to have to be borne out later on to understand this better.
And what's important to know about what...
Go ahead.
Just the one thing that I think is important with this Shea study, and this is affiliated with, there's a bunch of centers that the authors are from. There's Pittsburgh and Denver and St. Louis. This was a single center study, and again, you're always going to hear the variables like this is a single center study. It's observational. There's better data that we can use. There hasn't been any randomized control trials for this, but in this particular study, they had their massive transfusion protocol. So essentially anyone that activated massive transfusion protocol was enrolled into the study.
Right.
I tend to think that, and again, without speaking to the authors, just having read through the methods of this paper, that the 6-hour mortality in hemorrhagic trauma, I don't think it's weird that giving blood didn't reduce 6-hour mortality, because I think those patients are already moribund whether or not we know it in the first place.
Sure.
So in a massive transfusion protocol, you've got someone where the protocol is the patient has lost, let's say, 4 units of blood. So we're going to safely and rapidly infuse this blood, through wide sets and just get a whole bunch of blood into them. But a patient that loses a liter of blood and receives a liter of blood might have better outcomes than a patient who loses 3 liters of blood and receives a liter of blood. Right. So that 6-hour window, I don't think is super odd, but the 28-day thing is interesting to me because, again, is the 28-day mortality increased because of administration and reception of the blood product, or is it that there were other things that cause, and again, something that we have to consider too is trauma is a mechanism against the human body that we're not designed to endure. We're not supposed to survive traumatic illnesses or traumatic events. It's just not what the body is designed to do. So do you have someone who was in a motor vehicle accident where they, lacerated their aorta and they need massive transfusion, but they also have a pneumo from a rib fracture, and they also have pericardial swelling, and they also have this, and they also have that. So it's really difficult to say that, well, this patient lost blood and then we gave them blood and now they're better. I think that's a very difficult kind of thing to get to.
Yeah, I agree. The one thing I really did like about this study, and other studies have shown this, and I think the balance is starting to swing towards this being more medical fact than myth, is look how much less blood got used overall in these patients when we're using whole blood as opposed to component therapy. And, it stands to reason. People bleed. We said it before. People bleed. They lose blood. They need blood. They don't bleed components, and they don't need components. They need clotting factors. They need the plasma. They need the platelets. They need it. They need all the things that whole blood has inherently in its suspension that component therapy doesn't have, or for some reason, giving it as components does not give you what you need. And that's something we need to start maybe looking at that, like whole blood is where we need to be. And I think the studies are starting to show that if we use whole blood, we're going to use less blood products. There's going to be less shortages of blood products. Are there people that'll benefit from a unit of packed red cells? Of course there are. There's always going to be those people that are going to benefit from that, or people with medical conditions who need a 6-pack of platelets. I mean, it is what it is.
Right, but importantly too, it's not a one or the other thing, right? Yeah. Like it's not the debate isn't we should be giving whole blood or component therapy.
Right.
I think what it comes down to is a lot of places don't have whole blood because it's expensive and it's hard to store. Right. So if you get whole blood, there's only a handful of places in the country that give it. It's fairly expensive, and you have to
coming down, and the storage things are. It's kind of like old dogma. It's like, well, we're going to waste blood, but there's studies that show that people who use whole blood programs, you waste basically either at the average of what the blood bank wastes, or they waste less. And don't forget that whole blood that goes into circulation that's in the trauma bay or in the helicopter or the supervisor truck can be spun out into components, and you can extend the life of that unit of whole blood. So we're not throwing bags of blood away after 21 or 28 days. That stuff's just going back into the general population of the blood.
Right. It's not that the blood expires necessarily. It's a crude example, but like bags of saline have expiration dates on them too.
Yeah, sure.
So when you have a blood product, when you have a blood product that is taken out of refrigeration, it will just get moved back into refrigeration. It'll just be cryogenically frozen again. Yeah. Which is fine. So I do think there's a little bit of a myth over the pricing, but I do think that management and leadership is worried about pricing. And I also think they're going to be worried about use. And then you have there's extra training that has to go into it. So I think there's a lot of extra financial concerns for it.
There's always fences that will be put up to this stuff.
Sure.
You're always going to fight things, and you're always going to fight inertia. And the inertia is you're gonna have the blood bank people say, well, we've always done component therapy. Everything's fine. We don't have a problem here. If we give you units of whole blood, you're just going to waste it.
Yeah, and I don't know if that's true. So here we have two pretty good studies with blood administration. We have one that supports the use of whole blood, and another one that does not necessarily support the use of component therapy in addition to whole blood. We are interested in hearing what your program does. Do you guys carry whole blood? What do you all think about it? Make sure to click subscribe and like and all the fancy stuff on YouTube, because we are putting a whole bunch of stuff up on YouTube now. That is our Journal Club for this Monday. I'm Ed Bowder.
And I'm Dan Schwesser.
And we'll see you in one of our many other modules coming up on YouTube. So thanks for watching. We'll talk to you next time.
Take care.